It's time for a Puscast, review of the infectious disease literature with occasional comments. This covers the first 2 weeks of February 2016. And hey, in case you were unaware, Volume 2 of the Pus Whisperer is now available on Amazon. Yes, you can whisper pus twice over now. Head on over to Amazon.com and hey, buy my book. Otherwise, let's move on to the medical literature, shall we? Zika virus is the current panic infection du jour. What are the newest things about Zika virus? Well, the most important one, I think, is that besides its association with microcephaly and Guillain-Barré syndrome, is that it looks like it could be spread by sexual transmission. And DNA for the Zika virus can be found in semen for up to 10 weeks. That's a big problem, I suppose, for the Navy. Be that as it may, the current CDC recommendations are for abstinence or use of condoms for the duration of the pregnancy if a female has a male partner who has Zika. Unfortunately, the majority of patients who have this virus do not become symptomatic, and it's not known if an asymptomatic patient can also spread the disease. Also of interest, if you are unaware, Zika was first diagnosed or discovered in Uganda back in the 1930s. And thence it's been wandering around the world. It looks like it's heading back to Africa, and the virus may have changed a bit over the years, and instead of causing occasional diseases, has shifted more to the ability to cause epidemics. And of course, Africa is not well prepared for any infectious disease, much less a mosquito-borne illness. So this catastrophe will probably go from South America to Africa next. If you remember, the cases of chikungunya and dengue, I think it was dengue 4, first got into, I believe, Cameroon, and it took 3 years for those mosquitoes to take dengue and chikungunya across the country. So one would anticipate, that one being me, that it will speedily cross Africa in a mosquito as well. You can't stop a mosquito. As evidence, there are 250 cases of dengue on the Big Island in Hawaii in the last 4 months, and as a consequence, they have declared an emergency because of the dengue virus. If not Hawaii, then it will be Boston or California. These viruses are coming our way. So stock up on your DEET now, because it'll probably be gone by mid-July. DEET hoarding, what an idea. I'm sure prices will skyrocket like they did for doxycycline in the last couple of years. Flu season's kicking up. I'm doing this on February 20th, 2016, so it seems to be starting a little late this year. What are the benefits of flu vaccine always comes up. And besides preventing the flu somewhat, it's also interesting that influenza is associated with stroke and heart attack and atrial fibrillation. And if you get the flu, your chance of atrial fibrillation goes up. But if you get vaccinated and don't go and get the flu, it decreases your chance of atrial fibrillation by about 12%. This was a study out of Taiwan. So influenza vaccination probably protects against stroke and heart attack and atrial fibrillation. A nice downstream effect of the vaccine. And I like to harp on the fact that the effects of influenza and influenza vaccination are widespread and more than just one person getting the flu or not. People always say, oh yeah, well, the influenza vaccine doesn't stop flu-like illnesses. And the Cochrane reviews talk about flu-like illnesses. But flu is worse than flu-like illnesses. This study looked at illness severity and loss of work hours because of flu. And those who had influenza, the real deal, documented, were sicker and they had more hours of work lost because of the illness. And that those who were vaccinated did have a modest reduction in their influenza severity. So the flu vaccine may not prevent you from getting flu, but you may be less sick. And flu is worse than all the other flu-like illnesses. And not unsurprisingly, it's the poor that bear the brunt of influenza. If you are in a lower socioeconomic group, you are more likely to have bad flu with intensive care, ventilatory support, and even death. As is so often the case, it is those who are poor and who don't have infectious disease insurance who seem to get a disproportionate amount of bad outcomes from infectious diseases. As I said before, and we'll see if I'm right, I predict, I'm feeling psychic, that chikungunya, dengue, and Zika virus will all disproportionately affect the poor in the American South. James Randi owes me $1 million. At least he will when I prove this right. Donald Trump ain't ever gonna get any of those viruses. And also when it comes to influenza and who gets it, not unsurprisingly, in a study out of Japan, the more children you had at home, the more likely you were to get influenza when you are pregnant. Have vectors, get sick. And you don't want to get flu when you're pregnant. If you get severe flu, you're more likely to lose your babies. But on the bright side, if you get medications sooner, you're more likely to do well if you're pregnant with influenza. In a recent study of 188 women who gave birth while in the hospital for their influenza, 41 of them delivered preterm babies. Also, if they got early treatment of for their influenza, they had a 2-day stay versus a 7-day stay if they waited to get their oseltamivir. So oseltamivir does have good effects on interesting populations, i.e. those who are sick enough to get into the hospital. And here's yet another example of its benefit in the pregnant woman population. Of course, most of these women, 3/4, had not been vaccinated against influenza. And the question always comes up about how long someone with influenza is shedding. You can use their clinical syndrome as a surrogate for viral shedding. With influenza A, it looks like it peaks around day 1 or 2 of illness. Interestingly, for B, it tends to be slower to peak and last longer, with asymptomatic shedding up to 2 days before the onset of symptoms. And the shedding of influenza B may be a little longer than influenza A despite symptoms. Although certainly for A, it looks like you can use clinical symptomatology as a good surrogate for viral load. Given how rapidly influenza multiplies and then spews into the air, it's not surprising how infectious this beast is. 2 HIV curiosities. One was how long does it take HIV replication to go to 0? And it would appear to be a long time. This study found that even 11 years in, they were still having a slow decay of their residual HIV viremia. The other curiosity is a case of a patient who developed HIV and did not develop an antibody response. The patient rapidly progressed to have multiple AIDS-defining diagnoses and did not respond well to HAART until at month 49. 49 months. He developed an antibody response and then successfully controlled his HIV disease, demonstrating that although not perfect, we do need a humoral response to HIV to control the infection. I still can't get over 49 months to seroconvert. I had V1 zoster, 30 years ago or more now. I always remember being less than enthused by my ophthalmologist who said something to the sort, I think this might be due to chickenpox. He sounded uncertain. What are you going to do? What can you do to prevent zoster? Well, in HIV patients, BID acyclovir decreased the incidence of zoster. They had 3,400 patients. There were 26 cases in them what got acyclovir versus 69 cases in the placebo. And a pretty good P there, 0.001. That even meets my definition of statistically significant. Plus, there are other benefits of acyclovir in HIV patients since suppression of herpes in general tends to decrease the viral load. Also, for us old geezers, if you're 60 years old and end-stage renal disease, getting the vaccine prevents zoster. But here's, I think, the more important take-home. Quote, herpes zoster vaccination soon after the initiation of dialysis may provide greater protection. So as soon as that patient is heading for dialysis, we should probably get them vaccinated. And as long as we're putting the fear of viruses in you, how about measles? So this girl was admitted to the hospital with measles on day 4 of her illness. She had not been vaccinated. They then, during her hospitalization, checked for the presence of measles in the environment, and they were able to find measles in the environment on fomites, such as air specimens, surface specimens, and on the N95 respirators that were used as far down the line as 8 days after the onset of the rash. How infectious these fomites are, I do not know, but after wearing your N95, don't put it in your eye. How good are condoms for preventing the spread of HSV? I'm just going to read the results. Transmission of HSV-2 occurred in 68 couples, including 17 with susceptible women and 51 with susceptible men. The highest rates of transmission was from men to women, 28.5 transmissions per 1,000 unprotected sex acts. We found that condoms were differentially protected against HSV-2 transmission by sex. Condom use reduced per act risk of transmission from men to women by 96%, and marginally from women to men, 65%. The only thing I would observe is that they followed the patients for 18 months, and the data was per 1,000 unprotected sex acts. 1,000 in 18 months? Pretty good. These patients were pretty busy. Wonder if they got anything else done. Vaccines are also kind of weird. For example, the BCG vaccine decreases mortality in children, but it's not due to its effects on MTB. Similarly, the measles vaccine also has mortality, and it's not measles mortality, just all mortality. So these non-specific effects of vaccines are interesting. How about the oleo? That's what my grandmother used to call margarine when I was a kid. I guess the first brand of margarine was oleo. Not oleo, the oral polio vaccine, which I suppose could be oleo. In Denmark, it was associated with a lower admission rate for any type of non-polio infection. And this was compared to the DTaP vaccine. So there are some non-specific effects, perhaps, of the oral polio virus as well. Now that that is no longer being used, it will be interesting to see if these non-specific effects of decreasing infections return or actually go away. So a new spirochete that is associated with a Lyme-like syndrome has been isolated by the Mayo Clinic in 6 of 9,000 specimens from Minnesota, North Dakota, and Wisconsin. So while the bulk of Lyme is by Borrelia burgdorferi, there's a new one which the Mayo Clinic, long noted for their modesty, decided to call Borrelia mayonii, M-A-Y-O, Mayo, N-I-I. I suppose if you discover something, you get naming rights, but still. I did my residency in Hennepin County in Minneapolis, and our patients would often go to the Mayo Clinic to get a second opinion. They'd come back with all their tests repeated and the exact same diagnosis and therapeutic interventions, which is why I always told my patients who wanted to do this to hold the Mayo. Thank you. I'll be here all week. And I would not be surprised if they discover other Borrelia as time goes by that can cause disease in patients. All organisms that share the same name are not necessarily the same organism. Interestingly, in Uganda, there have been an outbreak of plague, and they looked at these organisms carefully and found that they were 2 different subpopulations of Yersinia pestis. So all the plagues throughout the world may not be the same. But from whence did plague come? This was cool. They took teeth from 101 individuals that were at least 5,000 years old and found Yersinia pestis DNA. They then used magic, i.e. molecular clock analysis and that sort of stuff, to figure that the plague started about 5,700 years ago and spread across the world. The very ancient plague genes lacked the ability to be spread by fleas, and it lacked the ability to cause buboes, so it would not have been anywhere near as infectious. But this puts the presence of plague 3,000 to 4,000 years before the big outbreak, or the first documented outbreak, the plague of Justinian. So it looks like plague spread across the old world, then it developed some new virulence factors, and then it killed about 2/3 of people. And it wasn't until 951 BC that the earliest sample of plague DNA was found to have the YMT gene, which is what allows it to survive in fleas. It's just amazing how they can pull this old DNA out and look at it and look at the evolution of plague, in this case, going back thousands of years. You don't get this kind of stuff in cardiology. I am definitely too old to learn new tricks, and one of the interventions that I have never quite been able to get myself to do is to suggest steroids for acute infections like cellulitis or pneumonia, or in this case, septic arthritis. Now, this was a study in kids, and I usually don't talk about studies in kids, that looked at the benefit of dexamethasone plus antibiotics versus antibiotics alone, and found the kids who got the short course of dexamethasone got better faster, although a smattering of the kids rebounded after the steroids were stopped. I don't know. I just can't quite bring myself to give steroids for acute bacterial infections. It seems an unnatural act. Like many practices, it probably won't change until I die off and somebody else comes along and makes it part of standard of care. So, an Alaska native hunter developed fever, a swollen finger, and a septic hip after harvesting seals. They looked and found a unique mycoplasm as the cause. No, it was not called Mycoplasma mayonii. It was Mycobacterium phococerebrale, Phocacerebrale. And this is not the first time this mycoplasm has been associated with seal finger. The report says it most commonly occurs of the middle finger of the non-dominant hand. I suppose that's the one you're holding the seal with when you smack it upside the head. And that is why it gets infected. Personally, I can't drive if the left middle finger is not functional. Interestingly, this mycoplasm belongs to a clade that is, quote, previously related to polyarthritis in elephants and raccoons and a domestic cat bite abscess. So it may be present in raccoons and cats. And humans do get bit by cats and occasionally raccoons, and I suppose even more rarely elephants. I always like to say that all the food we have and eat has a fine layer, a fine patina of stool on it, probably from all over the world. In the United States, we import a lot of food, and on it is poo. This study looked at where Salmonella borrelii came from in this outbreak in New York and the District of Columbia. And they traced it back to a specific salmonella from a facility in India that processed tuna. So it was Indian caught tuna that was contaminated with salmonella that was spread to the United States, where it caused an outbreak. It's amazing how these organisms spread around the world, facilitated by our food distribution infrastructure. It's why I only eat deep-fried food. Thank God the Mexicans invented deep-fried ice cream, and the Texans, their one beneficial invention provided to the world was deep-fried beer. Go Texas. But you never really know where that patina of poo came from to give you the diarrhea. Patina of poo, that would make a good glam punk rock name. I'm the drummer for Patina of Poo. And much to my surprise, patinaofpoo.com is available. We spent a 5-day vacation in Palm Springs, predominantly hiking in some amazing areas, the San Jacinto, the Indian Canyons, Joshua Tree. There is some stupendous hiking around Palm Springs. One night we decided to go see the latest Coen Brothers movie, and the girl at the window said, "Are you 55 or better?" Better. I told her it only gets worse after 25. There's no better. There's only older. And older is always worser. Well, almost always. I only bring this up because the New England Journal of Medicine has a review on urinary tract infections in older men. Not better men, older men, for your perusal. I'll tell you, the prostate doesn't get better. It just gets older and bigger. Or is that oversharing? For every study, as I've mentioned in the past, there's an equal and opposite study. And a recent study showed that Saccharomyces boulardii, one of the yeasts, doesn't prevent antibiotic or C. difficile diarrhea in patients on antibiotics. More interesting, though, is data to suggest that the microbiology of the bowel can promote healing after surgery. And so if you have the wrong microbiologic flora, you may be more prone to, say, anastomotic breakdown. And anastomotic breakdowns are the current bugaboo of our surgical wound infections. Is I don't know what we can do to prevent them. These are mice models, and people are not mice. They're sheep, right? No, not really. But one would wonder in the future if patients on antibiotics are going to be getting routine poo pills to prevent C. difficile or to treat C. difficile. And intriguingly, perhaps the perioperative antibiotics we give are shifting the flora away from anastomotic healing, and perhaps we'll be giving patients oral stool microbiome to enhance wound healing after anastomoses. That would be really cool. So sometimes the fine patina of stool we eat is bad for us, and other times it may be good, and sometimes it does nothing. Remember I said that vaccines have more effect than preventing one infection in one person? This study looked at the proportion of children in a given zip code for who completed their Prevnar vaccine, and found that there was an association between invasive disease in adults and lack of complete vaccination in children. So the way you protect us old folk who are better than 55 from getting pneumococcus is by having children vaccinated against it. Vaccinate the vectors, you don't get sick. And too many child protective agencies will get on you if you try to autoclave children. And as long as we're on the topic of pneumonia, there was a case report of Legionella being spread by human to human contact. There was a big outbreak in Portugal. A mother went and took care of her son with Legionella, and she got an identical strain he had, and she had never been to the source of the outbreak. So it appeared to be person-to-person transmission of Legionella. I would assume that the mother is a lot closer to her son in day-to-day care than, say, the average physician. Again, old dogs, new tricks. I've always thought that short-course tuberculosis therapy was stupid, that you should give drugs every day, you should give a lot of them for a long time, given the propensity of this organism to sneak through and develop resistance. And plus with oral therapy, even with DOT, you never really know about absorption. So I've always been fretting about short course therapy for tuberculosis. Certainly you may not have the resources in the third world to take care of it, but if you're in a country with resources like, well, I guess not the United States, but if you were in, say, an advanced country with a good healthcare system, again, not the United States, you'd want to maximize rather than minimize your treatment of tuberculosis. This study out of China shows that if you get short course therapy for your tuberculosis, you are more likely to have a treatment failure with an acquired MDR-TB pattern. So maybe some data to suggest that indeed it is not optimal to have people on short course chemo for their Mycobacterium tuberculosis. Now, here's a fascinating study. They looked at the risk of cancer in patients with latent tuberculosis and found they had an increased risk for a variety of cancers, including myeloma, lung, kidney, bladder, hepatobiliary, and gastrointestinal cancers. Why would that be? Certainly when you have latent tuberculosis and you do PCR on various and sundry organs, hopefully after you die, you find that patients with miliary tuberculosis have TB harbored in virtually all their organs. Is this chronic low-grade infection is causing the cancer, much as the way a chronic bone infection with a chronic sinus draining can cause a squamous cancer at the drainage site? I don't know. But what was curious is that none of the patients who received INH prophylaxis developed cancer. So taking your latent tuberculosis therapy may prevent you from getting cancer down the line. That is interesting. Now, association is not causation, and there are always problems with epidemiologic studies, but that's still interesting. One of the other bugaboos, since I do infection control for a living, is smear-negative tuberculosis. What are the characteristics of smear-negative TB? Well, they tend to have no cough, and they tend to have a radiographic pattern that is not typical of tuberculosis, and they tend to be smear-negative. The big question is, how infectious are these smear-negative patients? And that is still up in the air. And by the way, going back to that short course therapy, if you acquire resistance to tuberculosis on therapy, you tend to do worse than if you have initial resistance to those antibiotics. So putting people on short course therapy could conceivably produce more resistant tuberculosis, and if it does, the patients who do this are going to do worse than if they had had an initial infection due to an MDR-TB. So how about dexamethasone and cryptococcal meningitis? This study done out of predominantly Asia with a couple of African centers compared dexamethasone versus placebo for cryptococcal meningitis in AIDS patients who received amphotericin and 5-flucytosine. And those who got dexamethasone did worse. They had more adverse events. They had more disability. They weren't benefited. So don't give dexamethasone for cryptococcal meningitis in AIDS patients. And by the way, speaking of fungi, if you have run out of your Ambien prescription, the IDSA has new guidelines for the treatment of candidiasis. I love guidelines, but damn, they're boring to read. I have always been a wee bit skeptical that treating cysticercosis benefits the patient. This study was a meta-analysis of randomized clinical trials, and that for a single cysticercosis lesion, emphasis on single, albendazole and steroids made the cysticercotic lesion get better faster and made it less likely to have seizures down the road. So it's probably a benefit in a single lesion to treat the patient with steroids and albendazole. One of my many mottos is that cockroaches don't like the light. It's why I think the best thing you can do in medicine is transparency for everything you do, as uncomfortable as that is, because people tend to weasel about things. I think it would be wonderful, for example, if every surgery was recorded and handed to the patient. I think we'd have so much better technique in an OR if that was the case. The other is antibiotic prescribing, and interestingly, this study looked at making physicians justify their antibiotic prescriptions publicly and found that it improved their prescribing habits with the guidelines. Public behavior is always a little better than private behavior. Hey, we're done at 29 minutes, 49 seconds. References for this podcast are available online at edgydoc.com, where you will find the links to my growing multimedia empire, including Volume 2 of The Puss Whisperer, available on Kindle and Dead Tree versions. The perfect gift for the puss lover in your life. And seriously, who doesn't love puss? So I'm going to bring this to a close because we're going out for dinner and then seeing one of my favorite musicians, Emily Wells, at the Doug Fir tonight. Big Saturday night for us old geezers who are better than 55. Otherwise, thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I shall continue to follow along with you. Thank you. In dictation. Goodbye.